just want to really briefly give you a couple of case reports that I think reflects the value of ECMO in patients with massive pulmonary embolism, and give you a brief view of where it stands in terms of the literature on this subject. There's been a very long association between extracorporeal life support and massive pulmonary embolism. And in fact, the American cardiac surgeon, Dr. John Gibbon, who invented the first heart-lung machine in 1953, apparently did so because one of his patients died of a massive pulmonary embolus during one of his ward rounds, and so he was so shocked by that experience that it impelled him to really bring in the age of modern extracorporeal life support. Now, the first patient I want to present was a patient I asked him a few years ago that I think is a really pretty spectacular example of what can be achieved if you've got on-site ECMO support. This is a 50-year-old male who had a recent diagnosis of a DVT. He went to see his GP, was started on some aspirin. He came into RPA with bilateral leg ischemia, and on arrival he had low saturations or room air. He was tachycardic and hypertensive, and CT angiogram revealed the reasons why. He had an occluded aorta at L2, he had occluded superior mesenteric artery, he had bilateral renal and splenic infarcts, and he had bilateral massive pulmonary embolism, so spectacularly a case of both systemic and massive pulmonary embolism. So this is a CT angiogram. You can see his aorta still runs out of steam at about L2 here. There's really no flow distal to that. This is his right pulmonary artery here, pretty much occluded with embolus, and he's got some stuff on the left side as well. So he, as you'd expect, wasn't doing very well for very long and rapidly deteriorated hemodynamically. They had to go for an emergency aortic and SMA embolectomy. Now this, intraoperatively, they were able to actually establish flow down his aorta and into his ECMO, but he developed ongoing progressive hemodynamic deterioration, became severely hypotensive despite high dose noradrenaline and noradrenaline, had a blood gas with a pH of 6.79, PO2 of 47 and a lactate of 9, basic system minus 20. And the anaesthetist, who wasn't a cardiac anaesthetist but happened to be working next door to one, asked for ECMO support, which I think was entirely reasonable. So one of our cardiac surgeons came to the theatre, established vena arterial ECMO via the femoral vessels, so it was basically femoral vein through a pump, an oxygenator, and back into the femoral artery on the other side, very simple circuit. Because there was still some residual clot in the femoral artery, we actually had to do an embolectomy before we could even get the patient on ECMO, so that was normal. While that was all going on, he went into ventricular fibrillation. During cannulation, was successfully shocked out of that, and ECMO was established within about 15 minutes or so. And his echo at the time showed that he had this classic sort of right ventricular blown up acute appearance I've just shown you earlier, small hypertrophied underfilled LV. And here was the cause of his paradoxical systemic embolization. He actually had quite a large PFO. And this left atrium up here, anterior septum there, right atrium down here, and this is all flow. In this case, at this time during the course of his illness, it was actually from left to right, but obviously it had been right to left to produce this systemic embolization at some time earlier. So post-operatively, he was heparinized, we gave him a target of APPT of 60 to 70, 60 to 90 I should say. A couple of days later we scanned his head, which was remarkably uninvolved given the fact that he had this massive systemic embolus, so it seemed to be okay. He had a repeat CTPA which revealed the presence of residual pulmonary embolism. We then went to theatres with our surgeons who did an open pulmonary embolectomy and closed his PFO. Because he had persisting right ventricular dysfunction post-operatively, he went back onto VA ECMO and could finally be weaned day 4 with some inotropic support, and he had an IVC filter placed. So this is post-weaning. You can see that after weaning he's now got much improved right ventricular function, and he was fine from that point on. So day 5 he had a further embolus that was detected in his right brachial artery, so he had that removed surgically. Day 10 he was extubated, and day 21 he had the echo that I showed you that showed normal biventricular function and no residual pulmonary hypertension. Had a fairly prolonged hospitalisation afterwards. He was severely deconditioned by his ICU stay, but was discharged day 101, neurologically intact, with no significant organ dysfunction, no evidence of underlying malignancy, and was encouraged to take his warfarin. Now, case 32, sorry, the second case is a 32-year-old woman that actually had a massive PE in Canberra Hospital. This is from last year. She had a recent injury to her foot while she was on holidays, and then jumped on an international flight, and had a PE that she first presented at Goulburn Hospital and was transferred over to Canberra Hospital with a PE and DVT and saddle embolus. On arrival at Canberra Hospital, she was tachycardic and atrial flutter at around 220, again lowest saturations on room air, and hypotensive. She was thrombolised at that point, but had ongoing hemodynamic deterioration, and then went for a surgical embolectomy, which you can imagine was a bloodbath, and it was. Post-operatively, she had the left sternum open, she had massive transfusion, factor 7, and post-operatively she had severe persisting right ventricular dysfunction with low pH and steadily rising lactate up to 15 millimoles per litre peak. Now, Canberra is not an ECMO centre, so they refer us all their ECMO patients, but they can actually establish ECMO because they've got cardiac surgeons down there. So one of our cardiac anaesthetists flew down to Canberra with all our ECMO equipment. The local surgeon placed the patient on vena arterial ECMO, and the patient was transported back to Prince Alfred Hospital by helicopter with an open sternum post-surgically, which was remarkably well tolerated. She had ongoing right ventricular dysfunction, but by day 6 could be weaned from ECMO. She had an IVC filter placed. She had a fairly complicated ECMO run that actually involved hits and some vascular complications, which were all actually fixed up during the course of her stay at RPA. Fairly prolonged hospitalisation again, but ultimately she was just discharged well with no residual organ dysfunction, normal right ventricular size and systolic function, and no underlying cause for her coagulation abnormality could be found, and she was kept on long-term apixaban. And last time I spoke to her respiratory physician who had seen her recently, she was basically completely functionally normal. So what do the major international guidelines tell us about the role of ECMO in massive pulmonary embolus? These are the guidelines from 2011. These are the American College of Chest Physicians guidelines on the management of massive pulmonary embolus. And they make a very unenthusiastic recommendation for thrombolysis versus heparin, level 2C recommendation. They suggested that if that didn't work, that the patient should then go to surgical embolectomy, or they should have surgical embolectomy if there was a contraindication to thrombolysis, or if they were severely shocked and were likely to die within a few hours before thrombolysis could actually work. There's absolutely no recommendation at all about the role of ECMO in support of patients with massive PE in these 2011 guidelines. 2014, the European College of Cardiology put out their recommendations. The evidence in favour of thrombolysis versus anticoagulation with heparin is somewhat stronger, now 1B. Again, they suggested that surgical or catheter embolectomy should be performed if the patient failed thrombolysis, if there's a contraindication to thrombolysis, or if they're likely to die before it could work. Now in this 43-page document, the commentary on ECMO is exactly one sentence, and that is it can be an effective procedure. Now, I'm not having a go at these authors. The reason why they have made no recommendations based on the evidence is because the evidence just simply isn't there. And here's why. This is a review of 78 cases of massive pulmonary embolism from last year. The overall survival was 70%, very impressive. Patients that were in cardiac arrest had a 50-50 chance of surviving, again very impressive. And in 16 cases, ECMO plus heparinization was used. In 16 cases, all of whom survived. All sounds fantastic, but you have to bear in mind that this review was actually a review of 8 case series and 11 case reports, so very, very low quality data, prone to significant publication bias. So I think we really don't know the answer yet in terms of what impact ECMO has on survival. Should also point out though that even though we don't know what the role of ECMO is in these patients, but there's really very, very poor evidence on the role or the efficacy of thrombolysis versus surgical embolectomy. There's no data on thrombolysis versus some of the newer techniques such as percutaneous embolectomy or percutaneous embolectomy versus surgical embolectomy. So There's a lot of stuff we don't really know about how to best treat patients with massive pulmonary embolus in 2016. So based on our experience, we've done 5 cases within the last 4 years. Actually, no, 6 cases in the last 4 years that are pretty similar stories to this. 5 of them have survived to discharge. Our feeling is that ECMO, so the cases with massive pulmonary embolus should be managed in an ECMO centre wherever possible, so they should be transferred there as soon as possible, if that can be arranged. ECMO clearly, I think, in these 2 cases can and is life-saving. We know that it supports right ventricular function, and we know that it rapidly improves end organ dysfunction. We see rapid clearing of lactate, resolution of acute kidney injury if we can do this early enough. And so what I think our thinking is coming around to is it really should be part of an emerging sort of role in a bridge to decision, if you like. So one way that we can think of these patients, if they do have severe life-threatening cardiogenic shock, they've got a high lactate, they're falling in a heap despite maximal support, one option that's worth exploring is to put them on veno-arterial ECMO at that point. And then you've got time to sort out how to address the thrombotic or the embolic load subsequently, whether you keep them on heparin, and we re-examine them a few days later, whether you do a percutaneous embolectomy on ECMO, whether you do a surgical embolectomy down the track, or possibly even do thrombolysis, so that would be less likely. So I think for the Canberra patient, for example, if we followed this pathway, we could potentially have avoided her massive transfusion associated with open surgical embolectomy just after she'd been thrombolysed. We would have avoided the risks of transporting her several hundred kilometres by helicopter with an open sternum post-operatively as well for further management. So our advice to Canberra Hospital now would be that if you have a patient that's crashing with a massive PE, establish ECMO, put them on a cardiopulmonary bypass via the groin. They can actually do that there and come down, pick them up and take them back to Prince Alfred or St Vincent's Hospital for further management. There are some huge questions we don't really know about efficacy. As I mentioned, the evidence out there to support the strategy is completely lacking. Indications and timing are also unknown. So clearly what we really need is really good quality registry data to help us guide our practice. Good quality registry data would tell us if you had a big massive PE registry, for example, we could actually determine not only which cases were the fantastic triumphs with ECMO support, but those that were the epic failures as well. So that's all I have to say. I think we're all ready for lunch. Thank you.